Thanks for having me, everyone. Thanks for coming. Thanks to Sue Plan for making sure I got my slides in on time. Today I'm going to talk about robotic-assisted total knee replacement. I'm a robotic surgeon. I'm of the robotic generation. I really believe that in the next 20 years, most of these surgeries up here will have some sort of robotic or navigation involved in them. So I think this is the future, and that's what I'm going to focus on. I have no relevant disclosures to this talk. So we're going to talk briefly about what osteoarthritis is, and how easy my job is, because how easy it is to see osteoarthritis. We'll talk about conservative management to osteoarthritis, and then we'll talk about the meat and potatoes of this, the robotics and the technology piece. I'm going to walk you through a conventional versus a total knee replacement with robots. The specific robot I'm going to show you, we have at the Stanford ASC. We do not have it here at Greenwich Hospital yet, but I imagine it will be here by the end of the year, if it was up to me. And then we'll have some Q&A. So arthritis. Chances are someone in this room is suffering from arthritis. It's a common disorder. It's mechanical. It's wear and tear most of the time. If you drive a car 100,000 miles, parts start to go. It's the same thing with humans. I tell everyone we were built to live 40 years, reproduce by 20, die by 40. Now we're living to 100. You're going to have arthritis somewhere. It's progressive, and it often results in pain, deformity, and stiffness. And it has a major impact in quality of life and activity level. And that's why I love my job, because I can get people back to where they want to be most of the time. It affects over 27 million patients in the US alone. And if you're over the age of 75, 50% of you will have arthritis somewhere. The cause is multifactorial. We're not exactly quite sure. I simplify it and I say wear and tear, but we know there's many other components to it, like obesity, genetics, trauma, instability, and of course, age. So again, I tell patients in the office it doesn't take an orthopedic surgeon to show you what's normal and what's not, right? On the left side of the screen, that's a normal knee x-ray, and on the right side of the screen, it's not. One looks pretty, one looks symmetric, one doesn't. On the right side, you can see the arthritic knee. You get joint space narrowing and cartilage loss. Again, you're losing the treads on the tire, you're driving on a flat tire, and you're injuring your rim. That's my analogy I use every day in the office, and that's what arthritis is. You get these bone spurs and bone loss and bone reaction, and that's why the bone looks more white and hardened on the right side of the screen. In fact, when we go to the operating room, that white hardened bone is almost marbleized. It looks like a marble countertop, and it is very, very hard, much harder than normal bone, and that's just the reaction of the forces that are going through when you've lost the cartilage space. If the arthritis gets very progressive, you can have cysts in the bone, which is typical to bone loss, and we won't be focusing on that today. So I tell patients no one needs a knee replacement, people want it. No one needs it. What do I mean by that is you can live your whole life with an arthritic knee. It's not cancer, it's not a terminal illness, it's arthritis, right? That being said, there may be a point in your life where you'll want a knee replacement because you are not able to do the things you want to do and your quality of life suffers. And that's the time you come see me. That being said, there are conservative treatments of arthritis. All right, they're aimed at focusing on managing the symptoms and helping you feel better, right? It doesn't cure the disease. You can't come in, you can't say, hey, I want some regenerative medicine, I want to cure it like the bear implant. We don't do that. We use metal and plastic to replace the joint. We cannot cure arthritis yet, and we're not close to curing it. We're not even close. That's why I have a job. So what are the conservative treatments of arthritis? Things like physical therapy and exercise are great. They can help strengthen the muscles. They can help improve your gait. They can help give you more endurance. Again, it does not cause any impact on the underlying disease process. There's nothing that we know about yet that can really change that trajectory. It's going to happen independent of anything that we're going to do. Weight loss is super important though, right? Your symptoms might not be that prevalent, even if you have horrible arthritis. Maybe you're skinny or maybe you're not. Every pound of weight you lose is 5 less each step that your knee sees. So losing weight can really make your symptoms better. Medications, anti-inflammatories are the hallmark of treating arthritis. It's symptomatic management. It doesn't cure the process. It makes you feel better. Bracing maybe helps a little bit, can give a little bit extra support. And then there are things like injections, which are, again, Band-Aids on the result. So what's the cure? Well, the cure is metal and plastic, total knee replacement. It's a life-changing operation, provides pain relief, increased function, increased quality of life, and the economic burdens far outweigh the cost. It's reproducible and reliable, okay? However, if I tell all my patients, if I could just do one surgery, it's going to be what Dr. Chu talks about later today, and that's total hip replacement. And why? It's because the patients do so much better, and they feel so much more normal. So that's why I think robotics will eventually bridge this gap and help the knee replacement patients start to feel as good or maybe even better than our hip replacement patients. So patient dissatisfaction after knee replacement, it is a real concern. Only about 75% now feel normal after total knee replacement, whereas it's close to 95% feel normal after hip replacement. The recovery from knee replacement is intense. It is very painful. I tell patients that get hip replacements, you're going to feel better after the operation within 2 weeks than you do right now. Knee replacement, no chance. It's going to be at least 2 weeks, if not closer to 6. And I think honesty with our patients is the most important thing, because then they come into the office and they're not like this guy in the bottom right. They understand that this is going to be a process and you will ultimately get better, but it's going to take time. Dissatisfaction is high, kind of what Dr. Sethi spoke about. We don't understand why. We've studied it a million times, but we don't understand why some patients don't do as well and why they have residual soft tissue pain. The risk factors for patients who don't do as well with knee replacement are younger patients and more active patients, females, and also the lower socioeconomic classes. Our studies have shown they don't do as well, and we can't essentially find a direct cause for why these groups don't do as well. So obviously as surgeons, it can't be our fault, right? We have to blame the patients, right? Maybe we're just not selecting right. Maybe we're not setting the right expectations. Maybe the rehab protocols are wrong, but that's not it, right? Maybe we should be blaming ourselves. So this is a paper out of Rothman where I trained, and it really showed that 47% of early failures of knee replacement happen within the first 2 years, right? And this is related to a surgeon's fault, or things like instability, malalignment, component malposition, component fixation. Maybe our fixation techniques aren't as good. And we know that the surgical variables and the surgical technique plays a long role, especially in that an early period. So that's what led to my clinical question, right? When compared to conventional surgical technique, will robotic assistance improve clinical and functional outcomes? I mean, just look at the screen, right? On the left, that's me and my robot at the surgery center. That's Corey. She's the best assistant out there. And then on the right, that's what a conventional knee replacement looks like. I mean, technology versus something that's archaic. And I do conventional knee replacements all the time. But when I show this slide, I'm like, when you go to the mechanic and you're getting your tires changed, right? Do you want some guy going like this, going like this? Yeah, that looks good. No, you want a computer doing it. And then you want a guy looking at it on top of it. And that's the beauty of robot. I'm looking at it, and my surgical judgment is what is determining what I want to do, but then the robot executes it. This is the tools we use for conventional knee replacement. Archaic looking, still used throughout the country, and at our American Academy of Hip and Knee Surgeons, every year more and more people are adopting robotic technology. So these are some robots out there. Again, we've shown time and time again that the robots improve surgical accuracy and reduce outliers. There's no question that robotic assisted technology does that. And the early generations did that, and the later generations are doing that. But what we have failed to show, and we continue to fail to show, does it matter clinically? Is it meaningful, beneficial for the patient? There's been no good study that's shown everything that I'm tooting about robots, they're great, that it actually makes a difference for the patient. That being said, the robots are newer and the data isn't as long-term. I truly think in my career there will be a revolutionary study showing that robotic-assisted total knee replacements make a difference long-term for patients. Why? Because we could do all the cool things that Dr. Sethi showed in his slide, and we could do that in the operating room as well. So it's going to dynamically assess the soft tissue tension, and I can actually have my saw or my burr do exactly what I want it to do, and it does it within millimeters. There has been one small study that's shown that actually the partial knee replacement has had meaningful improved outcomes for clinical improved outcomes for patients, but total knee replacements, it has not been shown. Again, this just shows here that we do a better job at hitting our targets when we use robotic assisted technology. Okay, so now the fun part, and then I'll get you all going. So this is what robotic registration looks like. This is me mapping out the actual knee, the ankle center, and I'm mapping out the knee center in the operating room. There's the trackers on, and it's telling the robot, now I'm mapping out the hip center. So within about 20 seconds, I've mapped out the entire hip, knee, ankle axis. And the computer is able to calibrate, which is amazing. I don't understand exactly how it works, but it's able to calibrate exactly where the knee is in space. And And you can see here, based off of those trackers that are coming out of the bone, we know where the knee is in space. Now we go and we actually map the bone surface. This takes about 30 seconds, and we paint the whole surface. It's like paint by numbers, and the robot moves in 3 dimensions, and we see exactly what the bony anatomy looks like. And this is the most important part of the case that I believe. And this is the reason why I don't think we've learned exactly why we don't understand why patients don't do as well after knee replacement. And I think it's all going to be in our soft tissue tension and our gap balancing. So this is me balancing the knee and actually showing, before I made any cuts, what the ligaments are doing. So that graph on the right, it's a little blurry, sorry, shows the soft tissue tension. And this is telling me that in extension, the gaps are looser laterally than medially, which is common for a varus knee, which is a varus knee, and it's about 3 to 4 millimeters of gapping, right? Is that normal? I don't know, right? That's just what this patient has. And I think what we will revolutionize is, what is our target? Because I can hit the target every time, but the question that hip and knee surgeons still are looking to understand is, what is the ideal target? Is it too tight? Is it too loose? Is it just balanced? We don't know. And I think once we understand what the target is, we're going to improve our patient outcomes. And I think the target's not the same for Dr. Tomaszewski or Dr. Aversano or Dr. Merrill, because their alignment might be different to start and their soft tissue tension might be different to start. So I think AI and the ability to capture large data sets are going to tell us what we should be doing. And that's why I think it will make a meaningful clinical difference. This is the whole case. We've mapped the femur, we've mapped the tibia, and now I'm going to tell the robot what to do. Once this is done, the case is over. What I'm doing here is I'm actually manipulating the robot, the components, before I make any cuts. And I'm looking at it, what it will do on that bottom bar graph, on what it's going to do to the actual alignment and gaps. I could rotate the femur, I could distalize the femur, I could proximize the tibia, I could do anything I want here. And the idea is that I can look at the resection depths and I can look at the gaps and I say, is this the best for that patient? Eventually one day, it's going to say, oh, this is a 5'6" female that's 140 pounds with a pre-op alignment of X, Y, and Z, and I'm going to click a button and it's going to tell me what to do, and then we're going to do it. And I think that's how we're going to make meaningful clinical differences. And then this is what it looks like. It's really cool. It's paint by numbers. You can see on the left side of the screen is the computer that I'm looking at, and on the right side of the screen we're burring out the bone. So literally, it will not allow you to resect the bone that's not colorful. So what I'm doing here is just taking a burr instead of a saw, and I'm resecting within millimeters of all that bone with a burr. And it will not cut bone that it's not supposed to cut. It won't do it. And then we put the trial implants in, and we range the knee again, and we see how we did. So you can see here, we're within 2 millimeters of gaps. So I planned this knee a little bit tighter medially than laterally, because that's how he started, because he was a varus knee. And I think this is the best for him, but I still don't know, right? And I think eventually, no one knows, no surgeon knows. I think eventually we will learn more about that. This is what the x-ray looked like before and after. So you can see here, this is a varus typical knee, tight medially, loose laterally. And I left the knee in a tiny bit of varus because that was his native alignment. And that's what the post-op x-ray looks like after robotic-assisted total knee replacement. So in conclusion, arthritis is common and debilitating. Total knee replacement is a safe and successful operation, reproducible. We do a pretty good job manually. I shouldn't be knocking on manual surgery because I do manual surgery as well. We're pretty good, but we're not perfect. We're not a robot. And dissatisfaction rates are still up there after knee replacement. So I believe that in the future, robotic-assisted technology will help our patients do better after total knee replacement. And the real question is when will we show that? And I think only time and more studies and more data will tell. So thank you.